Hi, everyone. My name is Liz Lazo. I am the project manager consultant on behalf of the National Alliance for HIV Education and Workforce Development, also known as NAHUD. I would like to welcome you to today's webinar. Before we get started, I would like to review some housekeeping items. First of all, if you saw in the chat that my colleague Ashley has added a few questions for you. So when you get a chance, please go ahead and add your name, your organization, and the song that reminds you of summer. Throughout the session, we invite you to use the chat to engage with your fellow participants. And then for those who have questions throughout the session, questions for our speaker, go ahead and use the Q&A. The questions will be answered during the Q&A portion towards the end of the webinar. The session is being recorded, and the presentation slides and recording will be added to the website within 1 week. So for those who are not familiar with us, NAHUD is a membership organization of 8 regional and 2 national AIDS education and training centers, the AATCs, that support the AATC program mission. Established in 2010, NAHUD supports the AATCs, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, have an explicit directive to build and maintain a well-educated, culturally sensitive health professional workforce that can provide prevention, diagnosis, care, and treatment, and medical management for people at risk for and living with HIV. NAHUD collaborates with multiple organizations in order to promote and educate on the work of the AATC program. Since 2018, NAHUD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network, also known as ORN, to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, and recovery of opioid use disorder. ORN provides free resources and technical assistance locally in communities across the United States and its territories. Please visit the ORN website for more information in order to submit a request for technical assistance. For today's session, we are happy to offer one CME, CNE, social work credit, and or a certificate of attendance for attending our session. In order to receive the credit, you will need to complete the evaluation. The link to the evaluation will be added to the chat towards the end of the session. It will also be emailed to you directly one day after the webinar. Certificates will be emailed within 2 weeks of completing the evaluation. And even if you're not requesting credit or a certificate of attendance, we certainly appreciate your feedback in order for us to move forward with our series. As we come up with new sessions, we really listen to what is needed and relevant to the time. So please complete the evaluation. So at this time, I am pleased to introduce today's speaker, Dr. Brandon Marshall. Dr. Marshall is a professor of epidemiology at the Brown University School of Public Health. He is also founding director of the People, Place, and Health Collective at Brown University. Dr. Marshall's research focuses on substance use epidemiology with a specific emphasis on harm reduction and overdose prevention. He is passionate about conducting research that improves the health and well-being of people who use drugs. So at this time, I would like to go ahead and pass it along to our speaker, Dr. Marshall. Dr. Marshall, can you hear us?
Yes, hi, I'm not sure what happened.
Okay, we're ready for you.
Okay, great. My apologies, my Zoom just froze. Hopefully that doesn't happen as I present, but I'm going to go ahead and get started. Thank you so much, Liz. I will share my screen. Okay. I am thrilled to be here. I'm not sure if Liz mentioned, but I'm a professor in epidemiology at the Brown University School of Public Health. And I'm going to be speaking to you today for about 35 minutes on the role of overdose prevention centers in the United States. And my favorite summertime song is Steal My Sunshine by Len, which was a Canadian hit in 1999. So that both gives you a sense of my age and where I'm from. So to go ahead and get started today, I just wanted to highlight a few disclosures for you. I have research funding from Arnold Ventures, the Open Society Foundations, and the NIH, including work that funds our forthcoming evaluation of the overdose prevention centers in Rhode Island that I'll talk about later. I also serve as an expert advisor to the Rhode Island Governor's Overdose Task Force and our state's Opioid Settlement Advisory Committee, but these roles should not impact the perspectives and opinions that I am going to provide today. So our objectives for this afternoon here on the East Coast are to learn about what overdose prevention centers are and to discuss their history in the US and globally. There is a wealth of literature supporting their effectiveness from other countries. Vastly too much research for me to cover everything for you today, but I'm going to summarize some seminal findings from our work and from others that evaluate the effect of overdose prevention centers on people who use them and the communities in which they're located. And then I'll finish by a quick discussion on their continued implementation in the US and plans for their evaluation. So just to set the stage for you, I'm sure many of you might have seen a similar figure before, but we have an extraordinary overdose crisis in the United States that has actually been growing for more than 4 decades. This is a figure that was published in 2021 showing that drug overdose deaths in the United States have been increasing exponentially since at least the 1980s. I went ahead and plotted the number of overdose deaths in 2020 and 2021 on this slide, which were recently finalized. And in more recent years, we've been experiencing what you might call super exponential growth in this crisis, attributed in part to the toxic unregulated drug supply and the ongoing effects of the COVID pandemic in the US. So clearly much more work needs to be done to bend this trajectory. And I hope by the end of this seminar, you'll see how overdose prevention centers might be one intervention that help us achieve this goal. So what are overdose prevention centers? Well, these are quite simply spaces where people who use drugs can consume pre-obtained controlled substances under the supervision of trained staff. So drugs are not provided by staff on site. They are procured elsewhere and brought on premises to be used under supervision, usually by either medical professional like nurses or trained peers. We'll talk about the public health benefit of this supervision a bit later, but I want to highlight that overdose prevention centers are a lot more than the immediate overdose prevention that occurs as a result of this supervision. In the vast majority of OPCs around the world, clients can access a wealth of medical care and other social support services, including referrals to treatment programs. They're designed to offer wraparound services for people who are marginalized and have experienced often negative and discriminatory experiences in our health, social, and criminal justice systems. OPCs are not a new intervention globally. They have existed for more than 2 decades in Europe, Australia, and Canada. And there are now more than 200 operating in at least 14 countries. The terminology has evolved over time. I'll be using overdose prevention center today. That's the term that's increasingly being used here in the Northeast. But you might also have been aware of the term supervised consumption facility, harm reduction center, or in Europe, they are often referred to as a drug consumption room or DCR. For the purposes of today, we'll just consider all of these terminologies synonymous with each other and stick with OPC. So I want to take you inside for a moment the first overdose prevention center that opened in North America in 2003. It's located in the downtown East Side neighborhood of Vancouver, which was the site of an explosive HIV outbreak in the mid-1990s. That, in addition to an ongoing overdose crisis in the neighborhood, in addition to a significant amount of advocacy and policy work from the municipality and the province, resulted in the opening of this facility in 2003. It's what I call a Cadillac model of overdose prevention centers. It's a large fixed site facility with 12 consumption booths. They can be seen in the background of the photo here, where people, after registering to use the facility, will go to consume those pre-obtained drugs. Nurses, in this case, are stationed at a nursing station in the foreground, where they can passively observe people using and intervene in the event of an overdose. They might provide oxygen, naloxone, or offer other basic health services such as wound care and also injecting education. Sterile drug use equipment is also provided to everyone who uses the facility. That's obtained at the station when you go in to use one of the booths, and a typical kit is shown in the lower right hand of the photo. What's not shown here is the post-consumption room. So after people use in this consumption space, they move over to another room, and that's always where I say a lot of the magic happens in OPCs. That's where you might find peer recovery support specialists, nurses, health professionals, psychiatrists, social workers, helping to build rapport with people, figuring out what other services they may benefit from, and linking them to things like SUD treatment. In the case of Insight, there is actually a residential treatment program located on the second and third floor of this building, allowing people to be seamlessly transferred into a treatment program if they so choose, in addition to referrals to other SUD treatment modalities like methadone and buprenorphine. So that is one model of an OPC. I want to highlight that there are lots of other ways to think about offering OPC services which have been implemented around the world. Here we see images of a mobile overdose prevention center. This is a photo of one in my hometown of Kelowna, British Columbia, that is about 175,000 people, where people who are at risk for overdose are not necessarily located in one urban core, but might be disseminated throughout the community. And so a mobile service helps to ensure access to people throughout a municipality. It's basically a converted RV with two consumption booths you can see in the foreground of the photo, and other spaces that allow for provision of medical services. Overdose prevention centers can also be integrated into existing healthcare facilities. In Europe, there exist overdose prevention centers in emergency departments or hospital settings. On the right hand of this slide is an example of a small overdose prevention center that's integrated into a program providing services for people living with HIV in Vancouver. So only people who are accessing those services, HIV treatment and care, might also be able to access this integrated service within that larger program. So I want to move now to talk about some of the evidence that provides support for the public health benefit of overdose prevention centers. I'm going to walk you through 3 research questions which were a high priority for our team that was involved in evaluating the first overdose prevention center in Vancouver, and highlight some other research that's been conducted in countries such as France, and involving an unsanctioned OPC here in the United States. So we know that overdoses are effectively prevented on site. There has actually been no overdose death in any overdose prevention center anywhere in the world to date, showing that overdose death is preventable and can be effectively managed with the right clinical care and services provided. But one question we wanted to answer was whether these services actually reduce community-level overdose rates in the neighborhoods in which they're located. So to do that, I led this study that was published in The Lancet in 2011. I'll walk you through the methods really briefly and just summarize some of the key results for you. So this was a population-based retrospective study in which we were able to obtain data on all overdose deaths that occurred in the city of Vancouver between January 2001 and December 2005. I remind you that Insight opened in September 2003. So this study period allowed us to look at overdose rates before and after the facility opened. We were then able to map the precise location of overdose deaths using the 6-digit postal code, which in Canada, in urban areas, is essentially one side of a city block. We mapped all of those overdose deaths and then examined overdose rates within a catchment area consisting of all city blocks within 500, about 50 yards of the consumption service. And we did this because we knew from utilization data that over 75% of people who use the OPC reside in this small neighborhood. So we hypothesized that if we would see an effect on community overdose rates, it would be in this area immediately surrounding the overdose prevention center. And then we also examined overdose rates in the rest of the city of Vancouver overall, and essentially looked at the difference in overdose mortality in these two regions before and after the facility opened. So this is a map showing the location of all overdose deaths occurring in that 5-year time period in the city of Vancouver, and the location of the site, supervised injection facility, SIF here, sorry for that abbreviation, shown in the yellow dot. And you can see the clustering of overdose deaths occurring in that downtown East Side neighborhood over this time period, which is why the Overdose Prevention Center was located in the middle of that community. So these are the final results for you now. On the left-hand side of the figure, you can see the number and rate of overdose deaths, both before and after the OPC opened within that 500-meter catchment area. And to the right, you can see the number and overdose rate in the rest of the city of Vancouver overall over that same time period. What we found was a 35% reduction in overdose death rates after the facility opened only in that catchment area, compared to only a 9% reduction in the city of Vancouver overall. I'll show you these data now graphically and also in a map so you can see almost like what that looks like. So this now is a block by block visualization of overdose mortality rates in the downtown East Side neighborhood in that catchment area, with the location of the OPC shown by the red star. And we found reductions in overdose mortality rates in every one of those city blocks after the facility opened, which is shown by the lighter colors on the right-hand side. This is a final way to visualize the data. We re-aggregated the information according to census tracts, which are larger geographic areas. And we mapped basically the rate difference. So the overdose mortality rate before minus after it opened. So if that value is positive, that means overdose mortality rates were higher in that census tract before the facility opened compared to afterwards. And then we ranked the census tract based on how far they were from the OPC. That's shown in the x-axis. And what we found were reductions in overdose mortality only in the 2 census tracts that immediately surrounded the facility in the city of Vancouver, compared to stable overdose mortality rates in every other census tract over that same time period, providing again evidence that the opening of an overdose prevention center was associated with reductions in overdose mortality in these neighborhoods. So I talked about how overdose prevention centers do a lot more than preventing overdoses. We implement these facilities with the goal of increasing access to substance use disorder treatment. So this was another important public health question to examine, and I'll walk you through just one study that looked at this question. So this was a nice study that was published in 2011 that was a cohort study of people using the Overdose Prevention Center. Among about 1,000 people enrolled in that cohort, at baseline, 600 people were not engaged in any kind of treatment overall. And following these individuals for more than 2 years, the study authors found that over 40% had engaged in some form of SUD treatment at some point over that 2-year follow-up. That might include detoxification programs, methadone, recovery houses, or residential addiction treatment programs, for example. The authors also conducted what's called a survival analysis, which gives you the factors that are associated with an increased uptake of treatment over this 2-year time period. And those variables are shown in the figure. What they found was that regularly attending the OPC, and in particular having contact with peer counselors that are working in that post-consumption room, were associated with a 30% and 60% increase in the uptake of treatment over this 2-year time period. That's shown in the red box. The other factor that predicted entry into treatment was having a history of any treatment, which makes sense. Showing rather convincingly, I would say, that these services provide a pathway for people to enter into treatment and recovery services. So I want to move now to France. They are conducting an evaluation of overdose prevention centers operating in 4 cities in France. this is a wonderful article that was just published last year that looked at a number of outcomes associated with using what they call in Europe a drug consumption room. So this study evaluated non-fatal overdoses, abscesses, and emergency department visits in people who were using an overdose prevention center. A really nice strength of this study was that they also recruited people who were accessing other kinds of harm reduction services like syringe service programs, and they were able to compare these outcomes in people who used an OPC compared to people who used other kinds of harm reduction services. And what they found over a 12-month period is that people who used the overdose prevention center were found to have a decrease in overdose rates by 67%. They had a 79% reduction in abscesses and other skin and soft tissue infections. And there was an almost 60% reduction in emergency department visits, all compared to people who were using more traditional harm reduction services, showing again that value add that we see when we layer on OPCs on top of existing harm reduction services. So I want to move now to talk about what impact OPCs have on the neighborhoods in which they're located. This is an important outcome that we want to examine. You know, there's a lot of concern amongst neighbors, businesses, there's NIMBYism, which, you know, really do need to be addressed, I think, in any evaluation of an OPC that may open in the US or elsewhere. And so fortunately, we have some evidence that's already helped guide what impact OPCs have on some of these neighborhood outcomes. So this was a really nice study. We're going to do something similar in Providence here in Rhode Island when an OPC opens. I'll talk about that a little bit later. But in this study, they had research assistants and students systematically canvass the downtown East Side neighborhood in Vancouver 6 weeks before and 12 weeks after the OPC opened. And they had these students and research assistants count basically the number of publicly discarded syringes, the number of people injecting in public, and the amount of injection-related litter that were observed over this time period. And this is a visualization of those results. The opening of the OPC is shown by the vertical dashed line. So you can see that as use of the OPC increases, both the number of publicly discarded syringes, the number of people injecting in public, and the amount of injecting related litter all decrease. And this effect was consistent even after adjusting for other factors that could drive changes in these outcomes, such as police presence and changes in weather. This is a study that was conducted more recently that looked at the neighborhood impacts of an unsanctioned OPC operating in the United States. So we don't know where this is because it was operating illegally or without authorization at the time, but evaluation has still been possible. So this is looking at counts of police incidents reports for things like assault, burglary, robbery, or larceny theft in a neighborhood in which the OPC is located. That's shown by the green, and then 2 control neighborhoods in the same city, but that did not have an OPC. One, the control A, is the neighboring neighborhood, and the blue line is another control neighborhood that was most similar sociodemographically to the neighborhood in which the unregulated OPC was operating. And what you can see was that once the OPC opened, denoted by the vertical dashed line, we saw a reversal in the trend of police incidents reports over this same time period, a pattern which was seen in one of the control regions, but not one of the others. So suggesting, I think, certainly that OPCs do not cause an increase in disorder or crime in the neighborhoods in which they're located. In fact, they're often associated with decreases in some of these neighborhood-related problems as they're implemented. All right, so that's some research for you. I want to move now to talk about the status of their implementation here in the United States before we open it up for questions. So I talked about an unsanctioned OPC. There are now 2 publicly recognized and authorized OPCs operating both in New York City, one in East Harlem and one in Washington Heights by an organization known as On Point. There's been lots of media attention on these facilities. It's a nice article I linked to here at the bottom if you're interested. These OPCs operate under different models. The one in East Harlem is a more medicalized model, similar to Insight. You see the consumption booths in the background of the photo and the station in the foreground. The one in Washington Heights is a more peer-run model, so it looks a little bit different. Suffice to say, these facilities opened in November of 2021 and evaluations are ongoing. Staff at the OPCs have reversed more than 700 overdoses that have occurred in these facilities. No deaths have been observed, just like in any other OPC. And more than 2 people have accessed these services, and they've used these OPCs more than 48,000 times, showing that the need and the demand for these kind of services is quite large, at least in these neighborhoods, and that they're really preventing an enormous amount of overdoses that might have otherwise gone to emergency departments or hospitals in the region. I want to talk now about the status of OPCs here in Rhode Island. So we were the first state in the nation to authorize this intervention through legislation. That bill authorizing OPCs was passed with broad bipartisan support and was signed into law by the governor in 2021. As part of that law, the health department, our state health department, was required to develop regulations that would oversee the operation of these facilities. I provided a link to those regulations. I think they're very good, honestly. They're reasonable. The goal is to allow for low threshold services, but still provide a safe environment in which for these services to be provided. So those regulations were developed and promulgated in early 2022. We also, through our state's opioid settlement funds, have allocated $2.6 million for the operation of these facilities. And an organization was recently awarded the contract to implement OPCs in Providence, the capital of Rhode Island. And the opening is slated likely for early 2024. What's interesting about this model is that the organization has partnered with an opioid treatment program. And so they will be focusing on ensuring access to low threshold buprenorphine and methadone for people with opioid use disorder and other treatment modalities to people who would like to access treatment and care. So I want to finish now in the last few minutes by talking about how we're planning to evaluate OPCs. We know a lot about how they operate in other countries, but I would argue it's important to understand the impacts that they might have here in the United States, because our overdose crisis is much different. It's much more severe than in other countries. And we have a different context in which we're working in, specifically a privatized healthcare system and different policing practices, among other policy differences between here in Canada or here in Europe, for example. So my team here at Brown was recently awarded a grant from the National Institutes of Health to evaluate OPCs in Rhode Island. We're doing that in close collaboration with colleagues in New York University. Dr. Magdalena Cerda is my co-principal investigator at NYU, who will be leading research activities in Manhattan and elsewhere in New York City. And we are going to be doing a 4-year study to evaluate the impacts that OPCs have on people who use them and the communities in which they're located. So I'll just walk you through a few goals of ours before opening it up for questions. So we want to understand the individual health outcomes that are associated with OPC use. We're going to be doing this through creating what's called a prospective cohort study and linking OPC use patterns with administrative data that will give us information on overdose rates, emergency department use, and treatment for substance use disorders over the next 4 years. And similar to the French study, we're going to be enrolling a control group of people who are using syringe service programs but are not accessing an OPC. We're going to be following people for up to 24 months and asking people to come in and complete surveys every 6 months. In each jurisdiction, we'll be recruiting 500 people each for 1,000 total. And we're aiming in each jurisdiction for as each jurisdiction for about 250 people who are using an OPC and 250 people who are accessing syringe service programs to allow us to compare outcomes between these two groups. We're also going to be looking at the community impact of OPCs. We're going to examine changes in public health conditions, public disorder, and other neighborhood changes, say, for example, business activity in the neighborhoods in which OPCs are located. These are activities that we are going to be implementing right away as new OPCs are open in each jurisdiction. And we're going to do this through what's called a systematic social observation. So we have trained research assistants to systematically evaluate at random times throughout the day and week things like litter, public drug use, graffiti, and other measures of neighborhood disorder in the immediate vicinity of an OPC once it opens. And that will allow us to track neighborhood level impacts before and after a facility is implemented. We're also going to do this in a control neighborhood, which has not been done before. So for example, we will do this in city blocks that are surrounding an OPC, say neighborhood A, and then we're going to use matching methods to find a control neighborhood which does not have an OPC and do the same thing to really try to help us isolate the effect of an actual OPC on neighborhood level conditions over time. And we're going to do this remotely with an app that we've developed that our staff will access from their phones or tablets that will allow them pretty rapidly to collect very detailed information on the built environment and the social environment in these neighborhoods over time. Also, they will be collecting pictures anonymously and information about other changes in the neighborhood to really give us a very detailed look at the impact OPCs have on neighborhoods as they're implemented. And finally, we're going to be conducting qualitative and ethnographic methods to understand deeply how different program models and contexts change use and potential benefits on people who use OPCs in both jurisdictions. We'll be doing that through a rapid ethnographic assessment, which essentially consists of field work in and around OPCs to document some of these contexts, and qualitative data and interviews with both clients and staff who work at OPCs, including through linkage to the quantitative cohort data. So all to say, we're hoping to launch this evaluation very soon, and I hope you'll stay tuned for our results as we learn that we aim to publish them as fast as possible. So with that, I wanted to leave lots of time for questions and answers. I did want to finish by thanking study participants, our wonderful staff and students at our research collective, and again, my co-principal investigator, Dr. Magda Cerda, who's amazing to work with, and our other students at the Brown School of Public Health who have participated in this work as well. And finally, again, the original evaluation of the OPC in Vancouver was supported by the Canadian Institutes of Health Research. We have funding from the NIH to support our funding broadly, and the OPC evaluation is specifically funded from the National Institute by the National Institute on Drug Abuse and the Open Society Foundations. So with that, I just wanted to flash my email, website, and our team's Twitter page in case you'd like to follow us, especially as we disseminate findings from our OPC evaluation. So please do keep in touch. I want to thank you. I'm going to stop my screen sharing and turn it back to Liz, who will facilitate the Q&A.
Thank you, Dr. Marshall. That was excellent. And we do have a few questions already in the Q&A. And as Dr. Marshall said, if you do have questions, go ahead and put them in there and we'll go through them. So to start, does the treatment program include detox capability?
So it depends. So I'm not sure exactly which OPC you're referring to. Historically in Vancouver, detox was a common treatment modality. So many clients were accessing that type of treatment. In many OPCs, that might be one referral option, including many other SUD treatment programs, methadone, residential therapy, and so forth. As I mentioned, here in Providence, the OPC will be actually co-operated by an OTP with the goal of providing low threshold, seamless transitions into treatment for opioid use disorder if participants so choose. So at the end of the day, it really depends on the specific model and the way in which treatment is integrated into these OPC services. But yes, often that is one option for people.
Can you speak about what types of support certified peer specialists receive in these settings to help them avoid a recurrence of their own OUD?
Yeah, that is a great question. So, this, I will be honest, is a very challenging environment to work in. I've had the opportunity to meet with many staff who work in OPCs, including in New York City. Many describe it as a life-changing experience. They find great value in providing these kinds of services and care to people who are at risk for overdose and actively using drugs. That being said, it's not an environment for everyone. Other people, other peer recovery support specialists I've spoken to have stated that they would very much not prefer to be working in this kind of environment because they may find it triggering or traumatizing. So any operator of an OPC would need to think very carefully, I believe, about the staffing model and do a very thorough, comprehensive training and support program for staff who work in an OPC setting. So I'm not sure about the specific types of support models that are provided, but all to say, yes, that is absolutely critical. And I want to acknowledge that this is, an environment for specific types of people who really find a lot of satisfaction in, but is certainly not for everybody.
Do you know if it is legal in Virginia for needle exchange, and if there are any of these types of programs in the state of Virginia? Are there any OPCs?
So, as I am aware, as of today, I can give you the run through of what the landscape in the United States. So the only two publicly recognized or authorized overdose prevention centers are operating in New York City by an organization known as On Point. Those are the only two that I'm aware of that are currently publicly recognized and are operating. There are very likely unsanctioned facilities that are operating underground by grassroots or peer organizations that we might not necessarily be aware of. Here in Rhode Island, we were the first state to authorize OPCs through legislation. So any OPC that opens will be licensed and regulated by our state health department. In addition, just last month, the governor of Minnesota signed a budget bill that includes, I believe, $14 million for implementation of comprehensive harm reduction services that includes overdose prevention centers. Other cities have attempted to open OPCs, San Francisco, Philadelphia, but have faced numerous political and legal challenges. And so those efforts have been stymied to date. So that is kind of the state of affairs as I know it, if you will. I'm not aware of any publicly recognized OPCs operating in Virginia, although I'm confident that there are syringe service programs in that state.
And this seems to be similar, kind of building off that last question. Are there any other states you know of that now that they are also working toward authorizing opening OPCs?
There are, there's movement across the nation. There was a bill in California to authorize OPCs, which passed the House and Senate, but was vetoed by Governor Newsom last year or early this year. The federal government stance has been, I would say, equivocal so far, at least the Biden administration. So the Trump administration sued an organization that was hoping to open a facility in Philadelphia. That has gone through a number of legal twists and turns. They're now in settlement talks with the Biden administration. Really haven't heard very many updates for quite some time. But I think that lack of clarity from a federal level has in some ways made it more difficult for states to move forward, or at least what I have seen is politicians in some jurisdictions using that as an excuse not to move forward. You know, the lack of federal stance on this is a cover, I think, for many state and local politicians. What I will say is that we have moved forward in Rhode Island with our law. To my knowledge, there has been no interference at all from the federal government to date. And of course, we received funding from the NIH to conduct an evaluation of overdose prevention centers. And I hope that those research findings will inform some of these policy debates in other jurisdictions.
Great, thank you. So how will you select the control neighborhood? What factors are you considering?
Oh, that is a great methods question. I love it. This is actually like very challenging. We're struggling with this, to be honest. So we're doing a number of spatial studies. The one that I mentioned, the systematic social observation, that is the control neighborhoods are being selected based on locations of other syringe service programs operating in that city. If there are multiple syringe service programs location, we will randomly select one and basically create a catchment area around that fixed site SSP. So that's one way with that particular study that we will be selecting a control neighborhood. We are also evaluating other neighborhood outcomes using administrative data, for example, police arrests, or down the road, we would like to look at EMS runs, for example, for suspected overdose in these neighborhoods. And we're just embarking on that work in New York City, and it's been incredibly challenging to select appropriate control neighborhoods. We just presented this work last month at a conference and got some feedback on the approach. The problem, briefly, is that the neighborhoods in Manhattan in which these OPCs are located are unlike any other neighborhood in the entire city. They are highly policed. Historical arrest rates have been higher than anywhere else. And so it makes it very difficult to find appropriate controls when there has been so much police presence, surveillance, and low-level arrests in these specific neighborhoods historically, which, you know, is something that we were honestly not expecting and is demonstrating to us the challenge in some ways of conducting evaluations of these OPCs in the US when you have you know, so many unique patterns of policing, enforcement, and other, you know, functions of structural racism operating that make some of these methods more challenging than have been implemented in other settings. So that was a long answer, all to say we're working on it, but we've got a number of different approaches that we're trying to take to tackle this very challenging methodological problem.
Now, I've read about OPC working well in urban areas, but not being effective in rural areas. Do you have any knowledge on that topic?
Yeah, I love that question. This is so important. So yes, most OPCs internationally, are located in larger urban centers like New York City, Paris, Berlin, Toronto. But there are models operating in smaller municipalities and in rural settings, just like in my hometown of 175,000 people. Often mobile OPCs are implemented in these settings that can cover a broader geographic area. One really nice example is called Northreach. I'll put the link in the chat for everybody. I might not be able to do that, Liz. Oh, here we go. This is an OPC operating in Fort McMurray and Grand Prairie, Alberta, which are northern towns, very close in some ways to the border with the Northwest Territories. And so these are pretty rural, harsh environments, and they're able to operate successfully and have providing services to people who are at risk for overdose in those settings. So there are examples. There is not as much research, to be completely frank, so we don't know as much about their impacts and outcomes. It's certainly a place where I'd love to see more research and evaluation to understand how we could optimize OPC services in these kinds of rural settings, which are highly impacted by the overdose crisis here in the United States. So I would characterize this as promising. There are models, but we do need more research and evaluation in this particular area.
Now, how do you respond to critics who say you are doing nothing more than enabling serious substance misuse?
Yeah, that is one of the most common misconceptions that I hear a lot, and I think it's one that we need to study and evaluate, what we have seen to date, and we will actively examine this in our evaluations here in Rhode Island and New York City, is if or how using an OPC provides a pathway into SUD treatment services. And what other studies have shown to date is that, in fact, they do the opposite. They don't enable, they actually provide a pathway into healthcare, into SUD treatment and every other recovery support services. So, I understand the sort of immediate reaction. It seems like, yes, that is in some ways what these facilities are doing. I think that comes from a lack of understanding of the comprehensive suite of services that are being provided in these places. The goal is to provide treatment for people who want it. The executive director of On Point has said many times in public venues and to me personally that, almost all of the people that use the facility have some history of treatment. It's not that someone has never accessed treatment, it's that they have had very negative experiences in many of our SUD treatment systems. And the goal of the staff working in an OPC is to rebuild some of that trust and to connect people with them, more appropriate, non-stigmatizing and compassionate form of SUD treatment and care. So that's what's going on. They're making connections with people. And the moment that someone is interested in talking about treatment, staff are there to speak with them, help understand their needs, and connect them to services. So that is fundamentally the public health goal of OPCs, is to do that in addition to the immediate prevention of overdose and overdose death.
Did your research yielded any common findings related to implementation barriers of OPC, specifically in the US?
Yeah, the barriers are manifold. As I mentioned, there's only 2 publicly recognized OPCs open. There are legal barriers, as I mentioned, financial barriers. These are not inexpensive services. They take investment. The typical operating budget for a fixed site OPC might, be upwards of $1 million a year. But what I want to highlight is that cost effectiveness studies have been done in many settings, and these services have found to not only be cost effective, but cost saving. Why is that? Well, there are many unnecessary emergency department visits, hospitalizations that are prevented and averted as a result of the ability to manage these conditions on site. In addition to the treatment of HCV, HIV, and the prevention of other very expensive conditions to treat in our healthcare system, like endocarditis and other skin and soft tissue infections. So when you sum up all of those costs that are being prevented as a function of OPC services, and you do the math, they end up being cost saving. Now, that being said, though, it does take investment. And so in our privatized healthcare system in the US, finding funding models has been challenging. The opioid settlement funds that have been dispersed to every state and community are one path forward that we in Rhode Island have taken. There are other funding models that are being developed that involve a combination of private philanthropy and more traditional billing procedures for more traditional services, but the funding is a challenge. And then the third barrier I would say is NIMBYism. You do see this when you actually go to implement an OPC, a lot of community concern, misunderstanding. And so you really need to do that work, do that outreach, and get that community buy-in to help actually implement OPCs in a specific neighborhood. Surveys have been done, and the majority of Americans actually support overdose prevention services in theory. But when you actually talk about implementing it in a specific neighborhood in a specific point in time, that's where you tend to see more local opposition. And that has been a barrier in some places such as Philadelphia. So I think outreach, education, getting community buy-in, having a multilateral stakeholder engagement process are all ways to help overcome that barrier.
What strategies will you use to retain cohort members throughout the study and ensure data completeness, especially in Rhode Island where relationships with clients may be less established?
Yeah, that is a great, I love these methods questions. Thanks, everybody. So um, we have a wonderful staff here at Brown that have a lot of experience conducting research involving this population. We're doing the evaluation in close partnership with the organization that's going to be operating an OPC. You know, we need their support to be recruiting people who are using the OPC in that space. So our goal is to make sure that those research efforts do not in any way interfere with the provision of the clinical and harm reduction services. So we have to do that very carefully, very thoughtfully. And then we are fortunate to have a field office where we conduct the assessments. So people who are interested in participating will be invited to conduct that assessment at an off-site location that is private, secure, and allows for participant confidentiality. And then all of the data will be kept very securely in our secure computing environment at Brown called Stronghold, which we use in collaboration with NYU. So we're treating participant privacy and confidentiality very seriously and have a number of systems in place to ensure that that is maintained throughout the course of the study. So great question. Thank you for raising it. It's something that we always have to be aware of whenever we're conducting research involving people who use drugs.
Now, how do the people who are going to use the OPC site get transportation to Providence? Public, walking, or rip the buses?
Yeah, so this is something we do not know, and we will want to understand when we conduct the evaluation. In the vast majority of settings, they are in urban environments, and when you ask people, most are walking or using public transit to access a facility. That's the case in New York City and the case in Vancouver. We don't know exactly what that's going to look like in Providence. We do anticipate this being a statewide service, and so it's possible someone may travel farther distances to access the OPC. I hypothesize mostly, though, it will be walking or taking public transit to access the service. One thing I should note is that there are, many other services provided, sterile syringes, condoms, HIV, hepatitis C testing. All of that can be provided and can be accessed without using the consumption room itself. So many people use an OPC in a similar way they would an SSP or even a primary care clinic if clinical services are provided on site. So you don't necessarily need to use the consumption room to access all of those other services. So what I'm imagining is that the use patterns and the transportation patterns will be pretty similar to what we typically see through our other SSPs operating in the state, but only time will tell, and that's something we'll very carefully evaluate as the program is implemented here in Providence.
Okay. Are you including any mental health outcomes or feelings of connectedness in your cohort studies?
Yes, that's an outcome. I was just looking at the instrument today. We're very close to a finalized version. We're going to be piloting it over the coming months with partners here in Rhode Island before implementation. And that is definitely a domain that we do want to assess mental health outcomes, quality of life. And we've added some items around planned or planful drug use. That's something we've heard from OnPoint, that they've noticed that OPCs allow people to be more planful, proactive about their drug use, even if they're not always using an OPC. They've received injecting education or use harm reduction practice. It allows them to take more time and understanding on how to use drugs safely. And those are practices that they take with them that are very positive and are enabling people to feel more in control and planned with their drug use. And so we developed a few items that assess those kinds of constructs as well to see over time if those change. So yes, those are absolutely critical. I'm not sure what mental health services would or will be provided actually on site. That is something I'm going to ask the operators because that again varies across the world in terms of how much integration there is with mental health services generally. So that's something I need to look at, but hopefully I answered your question.
So I live in a very rural area with a very big problem. How would I try to get a program to come do a study in my state of Virginia?
Yeah, so I'm working a little bit with the state of Vermont on a similar kind of thing, very rural state. And, there's some interest in mobile OPCs. If you have mobile syringe service programs that are already providing services, you could start with asking them about what something like this might actually look like, whether it's feasible. There are other telephone-based or virtual services that are available, like Never Use Alone. So services that you can get people to call to provide virtual supervision, which may be feasible in more rural settings. This is, I think, an area where we need to innovate. So I don't have all the answers. I'm going to be relying on all of you to figure out how to do this most effectively in rural settings across the US, because as I mentioned, there really needs to be more research in this area. So those are a few ideas, but I'm going to be honest, we need to innovate and come up with more and then conduct that evaluation to make sure that what is happening is effective and providing life-saving support and care and services to people.
Now, before I continue, Dr. Marsh, I just want to say this has been really engaging, and we have several more questions in the chat in the Q&A pod. Would you want to take just a few more, or do you think you have a few minutes after one to still continue to respond to questions?
Yeah, let me get through a few. I do have to go around one. This is a good one. Before becoming an OPC, is it required helpful to have run a syringe distribution or similar service? I would say it's not required, but it's certainly helpful. That was the case in New York City. Those organizations had been running syringe service programs for many decades in those neighborhoods. What that offers the organization is a real understanding of the community, what the needs are, and a connection to people who would eventually go on to use an OPC. I think because they had that is why you see the utilization increase so rapidly in New York City. They had trust, they have rapport of the community. And then so as soon as they open an OPC, you see the use tick up rather quickly. I don't think it's impossible for other types of organizations to open OPC services, but you just would really need to think about, are we meeting the needs of the population? Are we listening to the population? Are we engaging people with lived and living experience in the design and implementation of OPCs? That's what's critical. So I don't think you have to have experience with SSPs. It certainly helps, but you do need to be listening to the community in order for these programs to be effective. Let's see here. Let's scroll up a little bit. Is it in the queue? I don't see any others, Liz. Let me see.
They're in the Q&A pod.
Oh, there we go. There we go. Yeah.
Sorry.
Okay, I got it. Yeah. Okay. Oh, I like this one. Has there been feedback on or opposition to OPCs from law enforcement? This is a really great question, David. Thank you for answering it. Yes, sometimes there is. In Vancouver, the OPC was implemented alongside changing in the Vancouver Police Department policy. So there was OPC implementation at the same time the police department changed their policy such that they wouldn't hassle and arrest people who were using publicly, but would guide them, take them to the OPC to use there. So that's a better scenario, is when you work collaboratively with law enforcement to change their practice to maximize benefit, public health benefit is the ideal. And that has what has happened in New York City. On Point, I've been told, has a very good relationship with the precincts in the neighborhoods in which they're operating. They speak very freely with law enforcement. They listen to their concerns, and they have a very good rapport with those precincts. And now there are police officers that do that. They hand out cards actually that have On Point's information, including the address and where someone can go if they come across someone, say, using in a park or on a street. So that is a better scenario. But opposition does exist and, needs to be addressed, I think, through a number of different ways. Often having more supportive law enforcement entities speak with more skeptical law enforcement can be an effective way, sort of peer-to-peer sharing, and that addresses some of the stigma and the discrimination. Ultimately, here in Rhode Island, these are legal, so law enforcement have to follow the law. So in our state, that's the approach that has been taken, is that they're a legal service. And so we will monitor and assess, but do not anticipate significant opposition in this setting. I think I may leave it there, Liz, just so we can give you some time to wrap up.
Yes, thank you so much, Dr. Marshall. So we want to thank everyone for participating today. We apologize that we did not get the chance to finish those questions, but they were very engaging. And I do invite, I believe, Dr. Marshall, you left your information before that. If anyone had some questions, they can reach you directly. So I advise you to take advantage of that opportunity. And you can, if you have your question, you can reach out to Dr. Marshall. I did drop the session evaluation in the chat. So please, we would love your feedback on today's session. And of course, thoughts on future sessions. And if you're seeking CEs, you do need to complete it in order to get your certificate. The next session in this series is 25 years of harm reduction in New Mexico and will be held on Friday, August 4th at 12 p.m. Eastern time. I did put the registration link in the chat. You can always visit the NAHU website event page on our upcoming events. So thank you, everyone. Again, thank you, Dr. Marshall, and thank you, everyone, for your engagement and participation. Have a wonderful day.
Thank you, everybody. Bye-bye.